today. These are the clinical scenarios which we see in our day-to-day OPD, like postmenopausal bleeding, endometrial thickness, very much high, and then tumor markers, benign, malignant, and then a final leading to the panel discussion on a very important topic. And with this, I invite, and my pleasure to invite Dr. Renu Mishra, ma'am. Ma'am is the president of the Gynae Forum South and the director of Kamna Fertility and senior consultant at Sitaram Bhatia. Let me say this, that all the webinars that we do, ma'am takes special interest. She monitors that every slide of ours is perfect. She guides us. We have learned so much from ma'am.
Now you're putting all the blame on me for the bad slides.
No, not at all, ma'am. अभी तक भी आपसे इतना सीखते हैं. It's always a learning phase to learn from you, and it's our pleasure.
Thank you, Shalini. So good afternoon, everybody, and a very warm welcome to all of you who have joined today's webinar hosted by Delhi Gynae Forum South. It's indeed an honor to have with us Dr. Sharda Jain ma'am, the founder and Secretary General of Delhi Gynae Forum. So we'll be discussing very practical issues today. So everyone is afraid of cancer. And as we get into the 40s and 50s, the incidence of cancer is bound to increase. As I always say and explain to my patients, that cancer is nothing but a disturbance of the balance between cell growth and cell death. And this is a very delicate balance. And as we get older, it is likely to go wrong. You know, the balance may go wrong. And it's like पुरानी गाड़ी होती है तो उसके पुर्जे थोड़े कम काम करते हैं. तो similarly, in a way, cancer is an aging disease. So now, as gynecologists, a good part of our practice is involving actually looking at how we can diagnose early cancer or prevent invasive cancer with repeated screening. So today's webinar, as Dr. Shalini has already said, that we will be talking about postmenopausal women, endometrial thickening, when do we need to biopsy, about tumor markers, about cytology, what to do if a cytology report is abnormal. And in the end, Dr. Panchampreet has promised us that we will be able to play online Tambola. So with this, hoping that we get some useful insights today from this webinar, and a very happy New Year to all of you.
Thank you, ma'am, for your kind words. And my pleasure to invite Dr. Sharda Jain, ma'am. Dr. Renu Mishra, ma'am, as highlighted, has told us that it's indeed an honor and pleasure to have ma'am with us. Ma'am is such a learned personality, and ma'am is the teacher of teachers. We all have been imbibing her teachings. No, ma'am, you would certainly deserve. And yeah, ma'am, एक second. Okay. So ma'am is fondly known as teacher of teachers, and ma'am is we all know that ma'am is the founder secretary of the Delhi Gynae Forum, which has bloomed into and mushroomed into 10 branches now, all the branches doing such wonderful jobs. There are many campaigns which ma'am is running and doing exceptionally good work, tirelessly working for all of us. And it's a great source of inspiration when we look at ma'am. She inspires us so much. Thank you so much, ma'am. And we just want to have pearls of wisdom from you.
I think today's session, which has been organized by Delhi Gynecologists South, I think interests everybody. It has a variety of topics. And in spite of that, it is commonly discussed, gynecologists get stuck up. And whether it's a thick endometrium in postmenopausal patient, how much thick, I think, again, there is a confusion. And then I think Madam Renu will also describe that sometimes even if the endometrium is less than that critical level, you can still find problems are there. So she will give you suggestions for them. Another thing is tumor markers are a bit expensive, and we must know exact place how they can help us in as far as detection of ovarian cancers are concerned. And lastly, again, the catch point is whenever you have an abnormal pap smear, what is the treatment strategy we need to follow? I think each one of us, we may call ourselves IVF expert or any expert, you have to come. A variety of patients of this kind will come to you. So I think you should be very crystal clear as far as the management part is concerned. And I think I'm very happy that Rama is here today to tell us on the very important topic about tumor markers in relation to gynecologists. So thank you very much again, Shalini and Dr. Renu, to invite me. And it's a pleasure of mine that I will be learning something.
Thank you so much, ma'am. It's really a truly an honor for us for your presence. So we begin our scientific session, and for that, I invite the chairpersons for the first talk, which is by Dr. Renu Mishra, ma'am. Welcome, Dr. Nimi Rastogi. Dr. Nimi is a dear friend. She, apart from not only the academics, she writes beautifully. She has written so many books, and it's a pleasure to read her books. She is the Chief Obs Gynae and owner of Sarthak Medical Center and advisor to the Health Planning and Policy, Government of Delhi. Besides that, she has so many positions. So I'm just cutting it short. Welcome, Dr. Nimi. My pleasure to invite Dr. Jaya Agarwal. Dr. Jaya is the, Dr. Jaya is the Senior Consultant associated with RG Stone Laparoscopy Hospital, Apollo Cradle, and Indraprasth Apollo Hospital. Welcome, Dr. Jaya. And with this, we begin our first talk. Dr. Renu Mishra, ma'am. I'll stop sharing, ma'am. Yeah.
Okay, so good afternoon once again, everybody, respected chairpersons. Why are we concerned about thick endometrium in postmenopausal women? Because when the patient is premenopausal, then the estrogen is making the lining grow. But the question arises when the estrogen production has gone down drastically, then what is making the endometrium grow after the menopause? So that is the worry, that is it cancer? So thick endometrium, just a minute, yeah, thank you. So endometrial carcinoma is a common gynae malignancy in postmenopausal women. 90% or even more present with postmenopausal bleeding. That's a good thing, so that most of these women are diagnosed in stage 1 unless they keep postponing seeing a gynecologist. It depends on age and risk factors. 1 to 14% of women who present with postmenopausal bleeding will have endometrial cancer. The risk factors include age, obesity, unopposed estrogens, polycystic ovaries, type 2 diabetes, and family history of gynae cancer. And transvaginal ultrasound is the most appropriate initial evaluation for the diagnosis of endometrial cancer. So we have two scenarios. One where patient presents with bleeding, she's postmenopausal, and another where you pick up thick endometrium, she's asymptomatic, and you pick up as an incidental finding for ultrasound done for any other reason or just for a regular health check. So in this study, there were 304 women who were more than 55 years and presented with postmenopausal bleeding. So if you see the mean ETs which they deduced from their study, these are average figures, that benign atrophic and pathology was seen in with a mean ET of 7.5 millimeters. With polyps, the mean endometrial thickness was 12 millimeters, hyperplasia 15, and cancer about 17. So these figures are by no means sacrosanct. You can have cancer below these figures, but these give you a general idea what is the kind of endometrial thickness are we looking at and what is the kind of predictive value for cancer. And 3 out of these 32 women who had cancer in this study had actually an ET of less than 4 millimeters. So that's why I said you cannot say that you can rule out cancer 100% in any patient, no matter what the thickness is, but these are the general guiding ETs. And also they said that at a threshold of 4 millimeter, the sensitivity or the diagnosis of cancer was confirmed in 90%, which increases to 97% when you decrease the threshold to 3 millimeter. So it's basically a trade-off. If you take lower threshold for doing a biopsy or evaluating the patient further after ultrasound, you will diagnose more cancer, but then it is going to be at the cost of doing much more interventions. That is, the specificity will go down. Another study said that the endometrial thickness less than 5 millimeter had a negative predictive value of cancer in 98%. So that means if you take a cutoff of 5 millimeter, you are likely to miss 2 cancers, but in 98%, you will conclusively rule out cancer. How about combination of endometrial thickness and the years since menopause? Is there any correlation? So this study looked at that and again saw the correlation between the endometrial thickness and the risk of cancer, that less than 5 millimeter in their study, they did not find a single cancer. And more than 9 millimeters, they found cancer in about 18%. Looking at the years after menopause, so women who had achieved menopause within the last 5 years, the risk of cancer or the cancer was found in 2.6%, whereas women who are more than 15 years menopausal, the cancer was detected in 21% women. So it does make a difference. That means as you get older and older, you are less likely to have a thick endometrium, which is normal. That is the essence of the study. And finally, this is the ACOG committee opinion on the role of transvaginal ultrasound in evaluating endometrium in women with postmenopausal bleeding. And they said that transvaginal ultrasound is appropriate for initial evaluation. If ultrasound reveals a thin endometrium less than 4 mm, then it gives 99% negative predictive value for endometrial cancer. So they have recommended a threshold of 4 mm for evaluating the patient. That means further biopsy. If blind sampling does not reveal endometrial hyperplasia or malignancy, further testing such as hysteroscopy with DNC is warranted with persistent or recurrent bleeding. So we have to understand that these guidelines are made for masses where infrastructure may vary, where expertise varies. So that is why hysteroscopy, although is not recommended for every patient, but if the sampling does not provide adequate tissue, or even after DNC, if you still find thick endometrium because you might have missed a polyp, then it is definitely not mandatory, but definitely beneficial to go on to do a hysteroscopy. So again, the committee recommended that because rare cases of endometrial cancer can present with ET less than 3 mm, so anybody who has persistent or recurrent uterine bleeding should have histological evaluation regardless of the endometrial thickness, because rare patients, these are outliers which can present with low ET. And ET more than 4 millimeter diagnosed or discovered incidentally should not routinely trigger evaluation for endometrial cancer. What about thick endometrium without bleeding? So this was a study where from China, a large study where they looked at 968 asymptomatic women who did not have bleeding, and they were found to have endometrial thickness of 5 millimeter or more. They were all subjected to hysteroscopy and endometrial biopsy, and they found total of 13 abnormal cases, 8 endometrial cancer and 5 atypical hyperplasia. And if you look at the mean endometrial thickness, which correlated with cancer, was 10.4, and which correlated with atypical hyperplasia, it was 7.7. So they recommended, based on their data, that the suggested cutoff for hysteroscopy and biopsy in asymptomatic women should be more than 8 millimeters. When you look at the rest of the 955 women in their study, which had benign report, then how does what is the spectrum of the benign pathology? So endometrial polyps were found in 72%, hyperplasia in 2.7%, fibroids in 3%, atrophic endometrium 12%, endometritis about 3%, and 5% had normal endometrium. So if you see, we were always taught that the commonest reason for postmenopausal bleeding is atrophic endometrium. Well, if you look in this study, they're talking about postmenopausal with women with a thick endometrium. If you look at postmenopausal patient who come with bleeding, then overall atrophic endometrium is much higher percentage than what we see in this study. But if you look at women with thick endometrium, then even I have, though I have not published my study, I looked at almost 10 years data of my own, and I found that endometrial polyps were in 75%, and cancer was diagnosed only in 2% patients. So majority of women who have thick endometrium and they are postmenopausal, they have endometrial polyps. That is why hysteroscopy really should be the gold standard if you have the facility and the expertise. Relationship between endometrial thickness and endometrial lesions in postmenopausal women. This study also concluded that endometrial cancer and precancerous lesions in postmenopausal women were much more commoner when these women presented with vaginal bleeding with endometrial thickness compared to asymptomatic women. And they, in their study, recommended that the threshold for predicting endometrial cancer and precancerous lesions should be 10.5 millimeter. So basically, when they say threshold for predicting endometrial cancer, they're basically saying that you go on to do a biopsy, whether with or without hysteroscopy. What about the role of hysteroscopy? So I'm just showing you two short clips to show how hysteroscopy scores over a standard or a blind biopsy. So this first video, this was a patient 65 years old. This is very old AIMS patient. And they referred to me because they could not do a biopsy because cervix was so flushed that they could not hold the cervix in OPD and could not do a biopsy. So the good thing about hysteroscopy is that you can go vaginoscopic. You don't need to hold the cervix, and you can look inside. Now you can see that the endometrium is completely atrophic, and the few red spots are the places where the patient has recently bled from. So once you have seen such a picture with your own eyes, you can tell confidently that there is no cancer. So that is the beauty of doing a hysteroscopy, because when you do in this very patient, if they had done a blind biopsy, probably they would have not got any tissue for biopsy. And then you are in a fix whether you have missed cancer or it is really atrophic. This is another patient who already had 2 DNCs, one under general anesthesia. This is when I was in Abu Dhabi. And they did not get a sample in any of the 2 DNCs. And patient then came because she was continuing to have spotting and bleeding despite the 2 DNCs. So they had recommended her hysterectomy. So when I put a hysteroscope in, you can see the majority of the uterine lining is atrophic, and there is a very localized growth, a polyp, which on removal was found to be benign. So she was saved of a major surgery. So majority women I have found have this polyp, which is malignant. And even if you find cancer, it is usually a very localized cancer and a very, very good prognostic outcome. So now these studies are basically focused to see how hysteroscopy can help. In this study, dilatation and curettage, it said, fails to detect most focal lesions in the uterine cavity in women with postmenopausal bleeding. So 105 women in this study with postmenopausal bleeding and endometrium more than 5 millimeter were included. 80% had pathology in uterine cavity, out of which 98% had a polyp. So DNC missed 58% polyps and 11% of endometrial cancers in this study. And they said the diagnosis in non-focal pathology was excellent with DNC. So if your ultrasonologist can tell you confidently that this is a generalized thickening of the endometrium, then a biopsy is very useful, and you can confidently rule out malignancy even with a blind biopsy or DNC. But the problem is that most of these women have focal or thickening or polyps, which do not necessarily come out on DNC. Sometimes you can and sometimes they don't. So diagnostic work of a postmenopausal bleeding, this was a randomized control trial where they took women with postmenopausal bleeding and an endometrial thickness of 4 millimeters and benign result on endometrial sampling. So these are women who had already had an endometrial sampling with bleeding, with thickness more than 4 millimeter. And then they went on to do a hysteroscopy, and it was found that focal endometrial atypical or cancer was diagnosed in 6 out of these 98 women who were reported to be benign on sampling. 3 had atypical hyperplasia and 3 had endometrial cancer. So to summarize, the cutoffs that you need to prompt histology or a DNC with or without hysteroscopy is generally recommended as 4 to 5 millimeters in women who present with postmenopausal bleeding. American College of Obs and Gynae takes it at 4 millimeter. The risk of cancer with ET more than 5 millimeter is about 7%, and less than 5 is 0.07%. If patient is on HRT, cutoff is 5 mm for evaluation. If patient is asymptomatic, now we do not have a consensus. There is a variable cutoff recommended between 8 to 11 millimeters. Again, figures show the risk of cancer with ET more than 11 is 7%, and less than 11 is very, very small. It's 0.002%. On tamoxifen, the cutoff should be 5 millimeters. So to give key messages, well, risk of endometrial cancer is very low in women with postmenopausal bleeding and ET less than 5 millimeter. However, you cannot confidently rule out cancer in every patient. Histological evaluation, therefore, is recommended regardless of endometrial thickness in women with persistent or recurrent bleeding. So if somebody comes with ET of less than 4 and you can recommend that patient can wait and watch, but she has another episode or she continues to bleed, then histology has to be done no matter what is the endometrial thickness. The cutoff in asymptomatic women is variable between 8 to 11 millimeters, and hysteroscopy and biopsy is the gold standard, though not mandatory in every patient. Thank you very much.
I would request Dr. Nimi and Dr. Jaya to give their expert comments.
Dr. Renu, excellent presentation here, and this is a very relevant topic because we encounter the dilemma every passing day, like where so much of paradigm shift in the evaluation. So there is so much of variability that even if the patient is not bleeding and the endometrial thickness is above 10, we can still hold a hysteroscopy, whereas even if the endometrium is 3 millimeter, 4 millimeter, she could still be harboring a malignancy. So under the circumstances, sometimes we also make decisions which are not appropriate. My question to you was that you say DNCs also can miss, blind DNCs can also miss endometrial carcinoma. So in tier 2, tier 3 cities where hysteroscopy is not available, so do we make the norms more stringent, or we rely upon TVS more, or like how do we go about it?
See, the reason for saying that is that most of these postmenopausal women who have thick endometrium has focal thickening rather than a generalized thickening. When you have generalized thickening, you will most of the time find cancer or atypical hyperplasia, but most of them has focal thickening. Now, when you do a blind DNC, sometimes you can actually pull out a polyp. Like it's a chance. Sometimes you don't, but you can't make out. So I would say for tier 2, 3 cities, if you do a biopsy and you can get a sample, and then but after doing a sampling, if the lining remains thick, still persists, like you've done a DNC, you got some samples, it says benign proliferative endometrium, but the lining is still 8 millimeter or 7 millimeter, then that means it could still be a polyp. So maybe what we could do is that if you can, you do a sampling, of course, as a first evaluation, but if either the patient continues to bleed or spot, or if you continue to find a thick endometrium despite your sampling, maybe she should be referred to tier 1 city for hysteroscopy. You cannot recommend hysteroscopy for everybody, but if you find that patient continues to bleed, she needs a hysteroscopy.
Okay. My another quick question to you is that will you dare to give HRT to somebody who's already endometrium hyperplastic stage, like less than like around 5, but no ATPR? No ATPR. biopsy done or hysteroscopy done, will you still give HRT if the menopausal symptoms are too daunting?
If somebody, well, you can, because if you have done a good evaluation and if it's benign, but I would say somebody whose endometrium is growing will not have such severe, menopausal symptoms because she's producing some estrogen.
Yeah.
Even the polyps, how you produce, some follicle suddenly decides to grow and produces some endometrium after menopause, and you get a focal thickening. That's how you get most of the polyps. So this patient probably will not be having such severe menopausal symptoms. But if you have done evaluation, you've done hysteroscopy, you've ruled out cancer, yes, you can give it. Why not?
Okay, and with rising incidence of premature ovarian failure and ovarian insufficiency, do you think the average age is shifting to younger age group for endometrial carcinoma? Does it have any correlation?
I have no data to either support or say against it. I don't know.
All right.
Can I pitch in a little bit?
Yes,
As far as you said, tier 2 or tier 3 city, Dr. Renu had already made it very clear that in case it's just like an FNAC, if it is negative, then you have to go and do a hysteroscopy. But if it is positive, it is positive. Where you find it is negative, you must get hysteroscopy done to rule out that patchy endometrial hyperplasia. And as far as, sometimes the patient with endometrial hyperplasia have symptoms. In those cases, you have to put in Mirena. The progesterone will become a higher hormone replacement therapy.
absolutely.
Yes. Yeah. Dr. Jaya?
Yeah, excellent presentation, ma'am. It's an honor for me to be the chairperson in your presentation. So the two very important take-home messages for all of us are, if a lady presents with a post-menopausal bleeding, then the chances of getting cancer are much more if the ET is more than 4 mm. And otherwise, if a lady is there without post-menopausal bleeding, and there is an incidental finding of thickened endometrium, then in the literature, I could see that 11 mm. One can wait. One has to decide, see for the risk factors, and then decide whether you want to do a DNC and do a biopsy to rule out cancer. One can wait if there are very less risk factor or no risk factor, even if the ET is up till 10.5 or 11 mm. Ma'am, what will we take the cutoff for the ETs if one is on tamoxifen for breast cancer, especially in post-menopause, or on HRT?
That is what I told you in the last slide, that the cutoff is 5 mm both for HRT and tamoxifen. Although if you look at studies, then the mean thickness with women on tamoxifen is about 8 mm. But for evaluation...
Yeah, that is what I found in...
Yeah, but the evaluation cutoff suggested is still 5 mm because they have more chances of hyperplasia. So you can find atypical hyperplasia, although majority will never have cancer or atypical.
Normally, we take a cutoff of around 8 mm.
No, cutoff which is recommended is 5, but they say most of the women will have mean thickness about 8 mm.
Okay.
I think,
That's
Yeah.
I would just say that a patient presents with bleeding, then given a choice, if you have the infrastructure and expertise, you should do hysteroscopy for all of them if they present with bleeding.
That's true.
Because even if it is atrophic, once you have seen it with your own eyes, like when I've done a hysteroscopy, I tell them, मैं 200% लिख के दे सकती हूँ तुम्हें cancer नहीं है, because seeing is believing. When you have very thin endometrium, you do sampling, you don't get anything, you're still wondering. But once you've seen it, so without bleeding, you may or may not do a hysteroscopy, maybe just to get hyperplasia or normal proliferative endometrium. But with bleeding, I think best is to put a hysteroscope in, if you have the facility.
So,
Correct. So we all,
with bleeding at times, hysteroscopy, people hesitate.
मैम, तो ब्लीडिंग तो बंद हो जाती है, वो नॉर्मली 1-2 दिन में सभी की.
उसके बाद ही करना है जब ब्लीडिंग बंद हो जाए.
बिल्कुल.
So, ma'am, just one question from my side. If the patient has postmenopausal bleeding and the ultrasound thickness is, like, say, 2 mm, then can we afford not to take a biopsy, just one episode?
Like I
or
said,
you still
2
would recommend?
millimeter 2 millimeter, you're very, very, very unlikely to find tissue, तो atrophic ही होगी. अब
Right.
उसमें you can always counsel the patient, you want 100% thing, let me put a hysteroscope in so I can tell you very confidently that there is nothing inside. If you
Right.
don't want to do it, you can wait maybe for another episode, because you know that the chances of cancer are very minimal. That's also a very honest truth. कि अगर उसको इतनी ज्यादा वो हाइपर और एंग्शियस नहीं है, तो यू कैन टेल हर टू वेट, रिपीट अ स्कैन आफ्टर अ फ्यू मंथ्स, or if she has another episode of bleeding, then you go ahead, because 2 mm is very thin, very, very less chance of having
Yeah.
a
True. So with this, I guess we wind up the first session after such an interesting and a crisp and with good take-home, crystal clear take-home messages. So thank you, Renu ma'am. Thank you, Dr. Jaya, and thank you, Dr. Nimi. And my pleasure to invite chairpersons for the next talk, Dr. Meenakshi Ahuja. Ma'am, are you there? Because ma'am had some laboring patient. Dr. Meenakshi ma'am, are you there?
can't see her.
Yeah, though ma'am is the senior
Dr.
director at
Shalini, she's
Fortis
there.
FM.
Dr. Vinay,
Actually, she's there.
I can see her.
Okay, yeah. So, okay, and my pleasure to invite Dr. Meenakshi Ahuja, ma'am, and ma'am is the senior director at Fortis FM. Apart from such academic-oriented and such scientific person, ma'am is also has a great zeal of life. She enjoys her life, and it's actually an inspiration that work and life should go hand in hand. Welcome, ma'am.
And we see it all the time on Facebook.
Yes. Good.
She's traveling also often.
How she manages both things, it's really still a mystery. I mean, she's both sound so academically doing so well on both the fronts. Okay, my pleasure to invite Dr. Pooja Sharma. She's also a dear friend and she's a consultant at Artemis Daffodil Hospital and director at Daksh Clinic, South Delhi. So pleasure to have you, Dr. Pooja. And I would invite the speaker for this talk, Dr. Rama Joshi ma'am, who probably needs no introduction. Ma'am is a legend in the field of robotic surgery and has done such pioneer work as a robotic surgeon. Currently, ma'am is the principal director and head of the department in the Department of Gynecological Oncology and Robotic Surgery at FMRI, Fortis Memorial Research Institute. So over to you, Rama ma'am. And we all are very eager to listen to your talk.
Good afternoon, all, and it's my pleasure. And at the outset, I would like to thank Dr. Renu Mishra for the opportunity. And I think the topic given to me is the tumor markers. And I'll try and make whatever the justice practically possible. And with this, I think I share the screen. So I shall be talking about the tumor markers, and really it becomes a dilemma sometimes what kind of the tumor markers we should advise to the patient and how we are going to interpret it, and what basic actually the common problem which we face most of the time is the complex ovarian mass. Complex ovarian mass is a situation where we all gynecologists or the GYN oncologists, these are really looking into how to best deal with them, because our aim is to offer best to our patients. And when we come to first, let's talk about the tumor markers, what these tumor markers are, and what are the different type of tumor markers, and I shall be taking into consideration for when are they raised, when are not they are not raised, what is the physiological limit, and how we should really be interpreting these. So in fact, the tumor markers are usually the soluble glycoproteins, and they are produced by the cells of our body itself. And of course, whenever there is abnormality in response to the cancer and certain even benign conditions, we do find that these markers are very much raised. Our concern is why we want to get these markers. Basically, in order to screen some of the conditions of the malignancy, can we screen, say, the ovarian cancer? like how can we screen, what type of the tumor markers we should really be looking at. And also when the patient is coming to us with some kind of the suspicion of malignancy, these tumor markers help us in diagnosing. And also we can know and predict even the prognosis of certain cancers by using these tumor marker levels. And also we can know that how good we are doing the treatment to this patient, whether this patient is really responding to the particular treatment. Most of the time, these are really helpful, especially when we are dealing with the advanced stage of the disease, with that of the chemotherapeutic management, and even after the surgery. Also, this helps us after the treatment is completed at the time of the recurrence. When we follow these patients up and we see that the markers are going up, it can be a recurrent disease. That is how the tumor markers are very, very important for the diagnosis, treatment, as well as, of course, the recurrent or the diagnosis of the recurrence disease. So ideally, the tumor marker should be that it should be produced by the tumor cells. It should have the high sensitivity as well as a specificity and can be correlated well with that of the tumor size, or in a way, you can say that the tumor burden. And of course, these should be diagnosed with that of the very simple tests by either in the blood or in the urine. And ideally, it should be inexpensive, but Madam Shada Jain has already mentioned about that some of the tumor markers are really expensive. So we have to choose that how we are going to really give the idea or give our order of the tumor markers. These are the various tumor markers which we come across, especially in the gynecological oncology, or whenever we are dealing with that of any gynecological patients. And in these cases, of course, we all are very much versed with. These can be the enzymes, or these are the hormones like inhibin, AMH, HCG, and also the oncofetal proteins like AFP and CEA, CA19.9, CA125. These are most commonly used tumor markers. Of course, even the receptors can also be taken and considered as that of the markers, and with that of the other hormones like testosterone. HE4 is also having some kind of the place being used as that of the tumor markers. Many new tumor markers are actually being worked on, but they are usually not being used in our practice, in our day-to-day practice. Once I talk about CA125, and I think we all are very much versed with CA125. And CA125 is usually a glycoprotein. And of course, this is the kind of this protein which is not very specific, but yes, it also gives us the dilemma in order to define what is the exact status of the situation whenever the patient is suffering with that of any kind of the ovarian mass, which is a complex ovarian mass or may not be complex ovarian mass, or maybe some other conditions as well. So when we look at the conditions other than that of the malignancy, we find that these are all conditions, or these are all day-to-day conditions which we come across with that of simple fibroid, adenomyosis. Endometriosis is, I think, the most common differential diagnosis whenever we have CA125. Sometimes the patient presenting to us, even in the markers in hundreds or thousands, we can have simple diagnosis of endometriosis. But endometriosis is a challenging situation where it is difficult for us to differentiate whether it is the malignancy or the endometriosis. But yes, we require to differentiate when we are dealing with the CA125, which is raised. And of course, the clinical implications are very, very important in predicting what we are dealing with. Simple situations like PID, cirrhosis, hepatitis. And if suppose I share one of my experience that if patient had some fever or any inflammatory condition, and even I mean to say pulmonary tuberculosis, you will find that the CA125 is raised. So raised CA125 doesn't mean malignancy, but yes, Clinically, we have to correlate, but if it is malignant condition, then what it can be. Most common malignant condition is the epithelial ovarian cancer, but it can be raised even in the cancer endometrium, especially when the disease is extrauterine disease. Whenever there is any metastasis to that of the lymph nodes or to that of the peritoneum, this marker of CA125 can be raised. Or it is the CA fallopian tube. Of course, CA fallopian tube exactly actually spreads like that of the CA ovary. So that's how the CA fallopian tube, or any condition which increases the size of the uterus and also the vascularity, like uterine sarcoma and immature teratoma, like the other ovarian tumors. It can be raised in the conditions like carcinoma, breast, lung, and colon. I just wanted to specify specifically for the CA125 because this is most commonly used tumor marker by us, and thus it's very important for us to know whether it is benign or it is malignant or it is physiologically. Like pregnancy or any menstruation, at the time of the menstruation also, you will find CA125 raised. So simple precaution of not advising the patient CA125 at the time of the menstruation, I think better when we know that, yes, that's how you have to actually give, rather, we can advise CA125 to our patients. And these are the physiological conditions, and it may not be, even if it is raised, one has been evaluated well, and you do not find any pathology, maybe it's a physiological increase. HE4 has been actually investigated, but this is also not that sensitive. But it is only one condition where it differentiates from that of the endometriosis. Most of the time, HE4 you will not find raised in endometriosis. So this is the only distinguishing fact of advising HE4. But in oncology, most of the time, we are not advising HE4 for actually, you can say, to evaluate the response and all of the epithelial ovarian cancer. We are sticking to CA125 because it is important in its initial assessment of the condition, whether it is ovarian cancer or endometriosis. Similarly, the other tumor markers, I think we are well versed with alpha-fetoprotein. Of course, the pregnancy, whenever there is any pregnancy, raised AFP doesn't mean anything until unless we have some clear-cut suspicion or very young age, less than 1 year of the child. If you go for the AFP will be raised. So these are the physiological conditions. And normally it is the glycoprotein, which you will find by the liver in the yolk sac, and of course the other, even the gastrointestinal tract. And that's how we have to see that whenever it is raised, most common situations are the germ cell tumors. Whenever AFP is raised means germ cell tumors. And whenever we are talking about the germ cell tumors, I think other situations can be the hepatocellular carcinoma, because when we differentiate our diagnosis and the patient is presenting with that of the liver lesions, these can be sometimes primarily raised in the hepatocellular carcinomas and the liver metastasis as well. So AFP is also very well known. Even in benign conditions, this may be raised. Most of the time, the levels are not that much, but we have to be careful even in interpreting the alpha-fetoprotein levels as well. And HCG, I think beta HCG, we are all knowing it. All the gynecologists are very familiar with it. Important is that the pregnancy and the pituitary adenoma, these are the two conditions, other than that of the malignancy, where we have to interpret the results very carefully. So whether we are dealing with the pregnancy or non-pregnant situations, and definitely what we are concerned about is the gestational trophoblastic disease and the germ cell tumors. These are the two conditions which basically define the increased levels of the human chorionic gonadotrophins. And that's how it is very, very important for us to interpret. Sometimes it is just the ovarian tumor. Patient is not having any kind of suspicion of the GTN, and you find that this is raised. And that is why we are ordering all these markers, which can be because of the, you can say, the germ cell tumor of the ovary in the younger age group, less than 40 years of the woman, when presents with that of the ovarian mass. Of course, one has to consider germ cell tumors, and these markers definitely we have to define. And these were the FIGO criteria that I think we all know, that how to interpret the results based on their levels, whether they are increasing weekly. And based on that, we can have the suspicion of the GTN or the choriocarcinoma. Similarly, CEA is another, actually the marker, which we usually get done initially with that of the CA125. And this is mainly because we require to differentiate whether it is ovarian cancer or whether some kind of the, the situation, the clinical situation where there is ascites, there are intraperitoneal disease, actually various, you can say, implants of the intraperitoneal disease, whether it is because of the colon or it is because of the ovarian cancer. Here it distinguishes that CEA, when it is raised, and CA125 can also be raised, and we may have to consider the ratio of CA125 and CEA in such patients in order to know that there can be either coexisting colonic cancer or it is CA colon, it is not CA ovary. So that's how this makes a lot of difference. And this is also can be raised even in some certain benign conditions. So having said that, the other third marker, which we are using in epithelial ovarian cancers, is CA19.9. The benign conditions also will be increasing it, but it is important for us to understand whenever CA19.9 is raised, always consider some kind of the, you can say, it is mucinous carcinoma. Most of the time, it can be even the gastric or pancreatic adenocarcinoma. These are the two actually differential factors whenever we are dealing with 19.9, but the levels can be raised in endometrial cancer, in immature teratoma, and even in some of the benign conditions like endometriosis. And this is how the LDH actually levels, which are in the dysgerminoma. Of course, these are very much raised. And we can very well actually, we can distinguish the type of the ovarian malignancy based on these markers, whether these are epithelial, whether these are the germ cell tumors of the ovary. And there are certain other situations like that of stromal tumors, and these stromal tumors do present the testosterone and DHEAS. And that's how we can actually know when patient is presenting with the virilizing symptoms, then of course we have to consider there can be stromal tumor, where the inhibin also plays a very, very important role, especially inhibin A and inhibin B. And usually we order inhibin B levels because these are comparatively raised, more pronounced than that of inhibin A. So inhibin B is a good marker for that of the stromal tumor, especially the granulosa cell tumor. And though the AMH is also raised in these conditions, but it's only in about, say, 75% of the patients of granulosa cell tumor. So usually AMH, we do not order, and we order inhibin B. There are certain tumor markers like squamous cell carcinoma antigens and all, but these are not usually being practiced. These have not been actually used in the real practice as such. So looking at these tumor markers, we have to advise these markers as per the clinical suspicion of the malignant condition. And this really helps us in differentiating whether these are malignant or the benign conditions, and also post-treatment follow-up. And it has to be interpreted accordingly, and one has to consider the physiological conditions if these markers are raised and ordered during those situations. So with this, I think I'll just quickly go for the complex ovarian mass. Whenever the patient is coming to us with a complex ovarian mass. I think you will all agree with me that this is the most common condition which every one of us has to really go through. It is very, very important to actually address the issue of the complex ovarian mass, because in this particular situation, we may be having the early ovarian cancer. So if it is early ovarian cancer, definitely the approach to this mass management of this particular mass will be very, very different. And our concerns are that how can we predict malignancy in such patients? Maybe by using the imaging of the ultrasound and also the MRI or the CT scan, how to interpret this. And that's how we can say that whether the mass is a complex mass, whether this is having some kind of the suspicion of malignancy or not. And so proper counseling, especially for whenever we are dealing with the patients of the complex ovarian mass, should be done. Because if we have the frozen section facility, we can know. And if we do not have the frozen section facility, then patient should always be counseled that this is a complex ovarian mass. And when we remove this mass, based on the final histopathology, of course, the management will differ if it is reported malignant, because in no way by which we can actually confirm the diagnosis on table other than that of the frozen section. Of course, it clinically one can make out whether we are dealing with that of the patients in the age group, which are very, very adolescent, or you can say the elderly, or they are in the reproductive age group. So the type of the malignancy, and you can say, and also the incidence of the malignancy can be interpreted based on these facts. And similarly, what kind of histology we are likely to deal with, that will also depend upon the particular age group we are dealing with. As you can see, the germ cell tumors are most common when we are dealing with that of the young adolescent girls. And that's how the complex ovarian mass, when we are looking at the complex ovarian mass, where we find that there can be a solid tumor, you can say it's a just, if it is an ultrasound report, also we will find that there can be the solid tumors and also increased vascularity if you go for the Doppler. And otherwise on CT scan, you will find that there is a nodule. This is actually solid nodule. So this is highly suspicious. There may not be any ascites in this patient. There may not be enlarged nodes or suspicious nodes in these patients. So it becomes a major surgical challenge for all of us. Should we go for open or minimal access is the first debate. We are concerned about the spillage, and why spillage is a concern? Because it can upstage the disease. And unfortunately, we cannot take biopsy from whenever the disease is limited to the ovary. So it requires frozen section. This is what is our concern. And concern is of the oncological safety. And also we are concerned about the fertility preservation as well as the surgical morbidity in these patients whenever these are presenting to us. Simple laparoscopic evaluation sometimes can really solve the problem. And when we look at the oncological outcomes, especially when we go for the minimal access surgery, of course, and also when we look at the stage of the disease, as the stage increases, naturally the oncological outcomes are going to be worse. And that is the reason people are interested in knowing how to identify, select the patient where we can go for the minimal access. Of course, surgery in these patients so that we do not compromise with that of the oncological outcomes. And frozen section also it's a challenge, because when we look at the frozen section report, how accurately we can predict the borderline ovarian tumors, or we can predict the malignant tumors of the ovary. That is also a challenge. It varies from center to center. It has been reported that about borderline tumors, you can detect with the accuracy of 83 to 99%, whereas malignant tumor from 96 to 100%. Why we are concerned about borderline tumors? Because once we think it can be borderline tumor, these are very notorious tumors, much more than that of the malignant tumors, because malignant tumors definitely are going to respond to that of chemotherapy, but the borderline ovarian tumors will not respond to chemotherapy. And we face a lot of problems where the patients keep on coming with the recurrences if suppose the rupture or the spill occurs. So it is a very, very challenging, and that's how there is a recommendation that how these patients should be treated, where these patients should be treated in order to give the best outcomes, as they are likely to undergo the surgical staging at the same time. There have been studies which have looked into the spillage and also the outcome of the patients going for the laparoscopic surgeries as well as the even say the open surgeries. And these all the results are. I basically wanted to share one video with you. I don't know. Yes. So actually, this is a patient where how we have done actually the minimal access surgery. This is, I hope. So this is a patient who was of 18 years of age. She was unmarried, and definitely she presented with these markers. You can say these markers were high. We had a suspicion of malignancy, and of course, looking into CA 19.9, 4020, I think we were thinking that this could be a mucinous tumor, which was a likely possibility. But at the same time, she had to appear for her exams and also has to go abroad. And that's how we had planned the laparoscopic evaluation. And after the laparoscopic evaluation, that's how you can see it's a huge ovarian mass. There was no disease onto the peritoneal surface, undersurface diaphragm, and everything else was good. So we decided going ahead with, since minimal access surgical approach by robotic, and there was no peritoneal spread of the disease, or there was no disease which we're able to see even on the ovarian surface. And that's how precisely actually this mass is being excised. It's very, very important not to rupture the mass. Of course, it is the way we are comfortable with in going ahead with that of the surgery and the surgical approach. But the main important actually consideration is that we require to follow the principle of oncology, that by just keeping it in the bag, I think we can't do it. We had taken simple, in this particular patient, it's a thick bag, and this is the Euro bag. And this was based on the measurement that is prior to going ahead for the surgery, exactly the measurement. And that's how you can see that even the surface of the mass has not been manipulated much. And that's how we are going to excise the mass. You can see the very nice, actually, the cautery system, which is very much there. What I feel is that while doing the laparoscopy, the consideration of, so much of the precision may not be there. And it's really very, very difficult to deal with the large masses. So that's how we took this back actually through the port. And since it's a very, very thick bag, and we had given a very small incision, cut, and then aspirated all the contents. And that's how the mass was taken out in the bag. What you can see here is like a bladder. There is no disorient.
Right.
You can say the
Okay.
anatomy is very good. So that's how actually it was just 5 milliliter of the blood loss. And that's how, with this, I think I thank you all. And this is what is the gynec oncology team at Fortis Gurugram. So thank you so much for your patient hearing. Any of the questions, I'll be happy to answer.
Meenakshi ma'am.
Thank you so much, Dr. Rama Joshi. Always a pleasure. You are anyway sort of a diamond in the Fortis crown, because we are all very relieved to have a wonderful surgeon like you with us at the Fortis group of hospitals. And I think the presentation was really interesting. The only thing I wanted to know was that, when we say that there is a differential diagnosis and all, is there a particular amount, because CA125 is what we most commonly deal with. So is there a particular number where we should think that, no, this is malignant, or can we be reassured that if this is a number, it is probably not malignancy and benign, or is it that just we need to follow up and see whether it's increasing or decreasing?
You are very right, ma'am, and thank you so much for your kind words. And CA125 most commonly we deal with. Now, normally, actually, the CA125 is less than 35 units per ml. This is what basically is the levels given. But let me tell you, even in stage 3 disease, in 10% of the patients, CA125 will not be elevated. So we cannot take CA125 alone for consideration. Now, CA125 may be raised to, say, in hundreds, 400 something or 500 something. And if suppose the patient is having complex ovarian mass or any of the ovarian mass, I think we have to be careful. It may be a borderline tumor, or it may be a low-grade serous tumor as well. So I think we have to consider that increase in the CA125, if it is in its hundreds and there is no other evidence of endometriotic kind of a situation, and if the mass is localized, as I have shown in this particular case. So I think we should take it with the suspicion unless we prove otherwise on histology. We really do not know what are we dealing with. Even these actually, the CA125 may be risen to more than thousands in endometriosis, severe endometriosis. And in thousands, when we see that the tumor is spread to that of peritoneal surface and is having a lot of ascites, that is the advanced stage of the disease as well. So there is no clear-cut correlation of the, you can say, the levels of the CA125 and the extent of the disease and the type or of the histology.
And when we are repeating the CA125 to see whether there's an increase or not, say a patient has a CA125 of say 75 or 80, and we see a complex mass that we they say probably endometriosis. How soon should we be repeating the CA125 to see whether it's increasing or not before deciding for a surgery?
I think you're very right. Endometrioma is the most common differential diagnosis in this situation. And we all agree that giving any kind of the hormonal treatment in endometrioma is not going to result in successful until unless these are especially the large endometriomas. So I think you can decide, but definitely you can defer the treatment if you are clinically suspecting that it is the endometrioma, where the patient can definitely be, followed up. You can follow these patients up at around, say, 6 weeks. So after the 6 weeks, you can go for the CA125. It shows further it is rising, because definitely you are going to put this patient on conservative management with the hormone. Right? So
yeah, thank you.
That is how we can do it. And we can take it up at 6 weeks.
Dr. Pooja.
Thank you, Dr. Shalini. So, Rama, it was treat to eye and ear, your presentation. So just to add to what Meenakshi ma'am was asking, how important is HE4 when you have a diagnostic dilemma of ovarian or endometrioma? Is it going to help us? As you mentioned that it is not increased in endometriosis.
In my practice, I don't usually go for HE4 most of the time. And it is the diagnostic laparoscopy. And if you think that it is the endometriosis, then we require to really prove that it is endometriosis. What we are dealing with is the endometriosis. Because we do come across clear cell carcinoma in endometriosis also, which we have seen in last year, 3 cases of the clear cell carcinoma in advanced endometriosis. So you will find endometriosis as well as the clear cell carcinoma coexisting.
Thank you so much, ma'am. Any more questions? I don't see any questions in the chat box. And Thank you, Rama ma'am, for such a wonderful.
Can I ask one question? Sorry.
Yes,
Yeah.
sure.
You know, this was about ovarian cancers, but sometimes you have a uterine mass or a fibroid where there is a suspicion of sarcoma. Maybe
Yes.
it's growing little fast. Most of the time you don't find it. But if there is a suspicion of sarcoma in a fibroid, do you recommend any markers?
CA125 you will find. CA125 you will find even in the sarcoma to be increased in levels.
So how like helpful is
But
it?
it is not very helpful at all. It is basically we have to go for the MRI and also the PET-CT. The combination of these two tests will definitely make a difference, and especially the clinical history that it has grown over in a very short time, and the patient is presenting with that of the vaginal bleeding.
No, yeah, vaginal bleeding is different, but most of the time they don't present with vaginal bleeding. It is just
If it is
increasing.
leiomyosarcoma, they will not. See, we are dealing with two sarcomas. One is endometrial stromal sarcoma. The other
ESS.
one
Yeah.
is the other one is the leiomyosarcoma. If it
Yeah.
is leiomyosarcoma, you are very right. There is no bleeding at all. The patient presents with a mass, and in the MRI will show us that there are a lot of necrosis in the tumor. And when you do the when we do the PET-CT, this increases. But as such, the markers of in the stromal sarcoma, we do not have the specific markers, but
some people do LDH.
yeah, LDH is the marker, which is actually true for many of the pathologies. Any kind of the malignancy can increase the LDH levels. So LDH is also not specific, especially for this, but yes, LDH is specific for actually, we are doing the germ cell tumor, right? That is dysgerminome. It is very specific.
Melanoma, yeah, is different. But
Yes.
about fibroids and this sarcoma business, very confused.
Very true. We are still confused. There are no definite markers.
Thank you.
Yeah. Thank you so much, Rama ma'am, for such wonderful talk.
Thank you
I mean,
so
we
much.
really learned a lot from you, ma'am, from your
Mishra,
talk. Yeah.
for the kind invitation, and thank you so much to Dr. Shalini as well. Thank you.
Thank you so much, ma'am. Ma'am, just one last question from me. If there is a complex ovarian mass, so what are the usual, I mean, you said you normally don't go for HE4, but what are the usual tumor markers that you like to get it done?
It depends on the age of the patient. If the
perimenopausal.
age of the if it is perimenopausal, most of the time you don't require to go for the germ cell tumor markers. One has to go for CA125, CEA, and CA19.9. These are the three markers we must get because we require to distinguish it whether it is because of the primary ovarian, or there is either coexisting, or there may be some basically the GI, or it is pancreatic. So we should go for three markers, not only for CA125 alone.
Very nicely.
I think finally we have to understand that tumor markers cannot really make a diagnosis. You know, they can help us to some extent. I just recently operated on a young patient, incidental diagnosis of an ovarian mass. And these CA125 was only borderline, CA19.9 was very high, and she had not even mucinous, she had a low-grade serous carcinoma.
Yeah, absolutely, ma'am. These are actually the bizarre presentations, and we really cannot actually differentiate much.
Thank you.
Thank you so much, ma'am. Thank you, Rama ma'am. Thank you, Dr. Meenakshi and Dr. Pooja, for your wonderful contribution. Moving ahead, we move on to the last session of our webinar today, which is a very interesting panel discussion. For that, we have Dr. Raka Guleria ma'am as the moderator. Ma'am is the director. There's a little error in this. Ma'am is the director at Fortis La Femme, and ma'am is also the vice president of the Delhi Gynae Forum South. Has also received the Distinguished Doctor Award, APJ Abdul Kalam Appreciation Award. Ma'am has a very charming and a pleasing personality, and has very, ma'am is so scientifically oriented. Nahin, genuine hai, ma'am. And welcome, ma'am. My
Thank you.
pleasure to invite another dear friend of mine, Pancham, who is always there as a helping hand to me. And little old CV, sorry. She is currently the associate professor at Lady Hardinge Medical College. And she has presented various papers, very sound academically. Welcome, Pancham.
Thank you.
Again, my pleasure to invite Sharda Jain ma'am, who is the expert for this panel discussion. Ma'am has such vast experience. We normally keep hearing in talks about the cervical cancer and the cervical cancer Mukt Bharat. So ma'am would be enlightening us with her knowledge. And it's apologies from Manju Khimani ma'am. She's not well. She couldn't make it to this webinar. And my pleasure to invite all my learned panelists. Sunita Malik ma'am, we all know ma'am has been the former professor and head of Safdarjung, and currently ma'am is the professor at ESI Medical College and Hospital at Faridabad. Ma'am has been is the chairperson of Gynae Oncology Committee AOGD 2021 to 2023. Ma'am is a great teacher. Safdarjung, I know vast experience of ma'am will certainly help us and will definitely enlighten us also. And ma'am has had various positions in the past also of AOGD. Again, my pleasure to invite Alka Gujral ma'am. Ma'am is in the same hospital. Yeah,
Good
hi.
evening.
Yeah. Ma'am is the director and unit head at Max Smart and with a special interest in laparoscopy surgeries. And ma'am has been the founder member and next secretary of Delhi Gynecologist Endoscopy Society. Welcome, ma'am.
Thank you.
And Dr. Poonam Sachdeva, another my mentor. I learned all my surgical skills from ma'am. And really pleasure, again, many publications, many presentations, and many positions. Dr. Sarit ma'am, real our pleasure to have you today with us. And currently, ma'am is the consultant and professor at Safdarjung Hospital. It's a pleasure and honor that she is the board member of International Federation of Colposcopy and Cervical Pathology and organized Asia's first IFCP World Congress of Colposcopy in July 21. And she's also the chairperson-elect of Oncology Committee of AOGD from 2020. I think the list is endless. Welcome, ma'am. Dr. Nina Behel, ma'am is the senior director at Fortis LaFemme, and ma'am has also held various positions in past, life member of AOGD and Foxy, and she's also received the President's Silver Medal and Best Graduate Award also. So with this, I hand over to, I request Dr. Raka ma'am and Pancham to carry on with the panel discussion.
So Pancham, you're sharing the screen.
Yes, ma'am. Just 1 second.
Okay. Good afternoon, everybody, and we welcome you to this panel discussion on abnormal cervical cytology. We see pap smears day in and out in our OPs, and we still don't know what to do about them. So hopefully by the end of today's discussion, we will try and gain some information on how to diagnose, treat, and counsel our patients. Because the next slide, which Pancham showed me, is mind-boggling. That we have more than 200 women dying every year of cervical cancer in India, 8 women dying every hour. So we really have to pull up our socks and activate our screening programs and try and prevent these women from contracting the disease, and if they do, how to screen it early and treat them. Before we start with the questions, Dr. Sunita Malik, ma'am, I would just like you to tell us what are the ideal screening tests to be done in our OPDs?
Thank you for inviting me for this panel, and that's there. Yes, as we know, there are this screening tests are as per the availability of the test, whether it's a resource-rich country or it's a resource-limited country. Ours is resource-limited country, so we have VIA, that is visual inspection after acetic acid. Then we have pap smear cytology, where it is available. HPV, that is what WHO recommends as a primary screening method. And of course, if further we need is, we can also do those mRNA testing and the Aptima, the E6, E7 testing, all these tests are available. And then we have these days we have AI-based screening test also. That is, in fact, magnified VIA images with smartphone, and we can do that also. So these are the tests. So ideal is, again, VIA till reproductive age group and cytology after menopause. Both have almost equal sensitivity and specificity. And the best is, of course, HPV screening as alone or co-testing with cytology or VIA. These are the screening tests which are available. Yeah.
Thank you, ma'am. Pancham, can you just take over now?
This slide just shows the comparison between the conventional PAP and the thin PrEP. Thank you so much, ma'am, for elaborating on the screening test. This is a quick just view over the conventional PAP on the left and the liquid-based cytology on the right, which is much more accurate, and it clears off the debris and the elements, etc. So coming on to our first case scenario, again for you, Dr. Sunita Malik, ma'am. This patient was a 39-year-old para-2 living 2 who came with complaints of discharge per vagina on and off for the past 2 weeks. There was no history of postcoital bleeding. On examination, the abdomen was soft, non-tense, non-tender. Perspective examination showed the cervix to be healthy, vagina healthy. There was no obvious discharge. LBC was taken for this patient and the PV findings were normal. So when we got the report, it was ascus. If I may ask you, how will you proceed with this report in this patient who was a 39-year-old woman?
So we get a report of ascus in 39 years is ideal is again to go for HPV testing, high risk HPV testing. If it is negative, then we can go for routine screening after 5 years. If it is positive, we further proceed to colposcopy or biopsy. But if HPV is not available, which is there in most of the centers, then we can, it all depends whether she's very non-compliant patient, then we straight away go for colposcopy, VIA and biopsy. But if otherwise, if we think she will come for us for the follow-up, then we can repeat cytology at 6 months to 1 year. 1 year is also acceptable. Negative, she goes to routine. If it is persistent ascus or goes to LSIL, then we further proceed for colposcopy and biopsy. And of course, that is there. So it depends on further, whatever result comes, we manage it like that.
The advice for the HPV DNA testing. So
yeah, HPV DNA testing is ideal is to do HPV DNA testing along with. There could be co-testing or reflex testing. So it all depends on that.
Absolutely. Thank you, ma'am. And suppose if this report would have come in a post-menopausal woman, then what should we do?
Post-menopausal women, again, we need to have immediately do HPV, but we may not get cells since the junction is inside. We may give her estrogen treatment for some time, whether by vaginal route or by, ideally is of course vaginal route in the form of creams or tablet, or it could be oral Premarin for 6 weeks, and then we can repeat the smear, and better is again to do co-testing and then proceed further.
The HPV, can I just say something?
Yes, ma'am, please.
Yeah, so the HPV test, I mean, patient need not be brought again for the HPV test. The same sample, if it's a liquid-based sample, the HPV can be done on the same sample.
That's right.
So, absolutely, absolutely. Anyone else would like to share anything on this case scenario?
I think that's what's called reflex testing, when you do the HPV testing in the same sample of your LBC. I think that's what Dr. Sarita suggested.
Yes.
That's what I said. It is co-testing or reflex testing. You know, reflex testing is we do it afterwards. So after on the same sample, that's there.
Thank you so much, ma'am. Thank you. Moving on
to not co-testing for screening is not recommended because they have not found any evidence of benefit with co-testing. So either so it is primary HPV screening. So screening should be by just HPV testing, and if HPV is positive, then go for further test for triage.
No, that's there, but co-testing, if it is done at the same time, then that one triage part is already there. So we
Yeah,
can
but then
further
if it's
proceed to
HPV,
colposcopy, you know.
yeah, but if there is HPV negative, then there's no need
Yeah,
to
of
do
course,
the
negative, then
yeah,
that's
it's
okay.
only if in HPV positive, then of course.
Yeah,
then
so
we can.
that's the, as far as results are concerned, it's the same. But if it is done at the same sitting, it avoids, you know, all this.
Yeah, but I think in private also one has to think of the cost to the patient, and if there's no benefit with an additional test at the same time, then that can be avoided.
Yeah, I would request the field people to please let me show my video. I'm unable to show my video. So moving on to the next case, she was a 45-year-old parrot who living to who came for a routine checkup. On per-speculum examination, there wasn't cervical erosion on the posterior lip. The vagina was healthy. LBC was taken as a part of opportunistic screen, and per-vaginal findings were normal. The report came to be LSIL. I request Dr. Alka Gujral, ma'am, how will you proceed with this report if you have LSIL with the patient?
Yeah. So if it's a low-grade SIL at perimenopause, we can ask this patient if our resources allow for a HPV testing. So if it's HPV positive, definitely we would like to go for a colposcopy, colposcopic biopsy, and accordingly treat the patient what the biopsy reports come. But if the settings are like that you cannot do an HPV testing, then you can allow this patient to repeat screening after 1 year. If it's HPV negative, then definitely you ask the patient to repeat the screening test after 1 year.
Yes.
So if HPV positive, it's very high likely that it may be a cancerous CIN3+. So you will definitely do a colposcopy. But this negative, then you can screen this patient after 1 year. Again, with LBC or with co-testing HPV with LBC.
Suppose we don't have a HPV DNA testing facility available.
Then you repeat the test, same LBC test after 1 year, because it's low-grade cell. Low-grade cell takes time to progress into a invasive or CIN3 stage. So you can just screen them after 1 year again. If it still shows a low-grade cell, then you have to subject these patients to colposcopy and colposcopy-directed biopsies.
Yes,
At the same time, if the patient can, then HPV testing can be done at that time after 1 year.
Patient needs to come.
Guidelines as per the WHO and also the guidelines that we had made, the FOXY GCPR guidelines. So anything which is more than ASCUS, we'll need to go for triaging. So either if HPV is not available, then the other triage test, that is colposcopy, should be done. So these are the guidelines. So this should be followed. So anything more than ASCUS needs colposcopy. Okay.
So in this patient, we did a HPV testing. It came out to be negative. So we advised co-testing after 1 year. It came out to be LSIL with HPV positive, and we did a colposcopy. So these were the colposcopy findings. If we went through the SWED score, so it came out to be 6. And transformation zone was type 1. Punch biopsies were taken from 2, 4, and 7 o'clock positions. And the report came out to be CIN1. If I may ask, how will you proceed, ma'am, with this report, and how will you follow up this patient?
Yeah, if it's a CIN1, like first thing, one is patient has to be counseled, and she's 45, so we hope that the family is all complete. So in CIN1, either we can go for a minimally invasive procedures like LEAP, just remove the transformation zone, or if she is not willing to follow up or she stays at a remote place, we can even go for more invasive procedures like an hysterectomy. But the patient has to be counseled. A minimally invasive procedure like LEAP can do, and then after that, she can follow with the LBC reports.
Why hysterectomy? Why?
No,
Dr.
if the
Gujral?
patient stays at a remote place and she is not willing to follow up in that case, otherwise we have to do the LEAP conization.
No, but even if you do LEAP or whatever, if you do LETs, you're going to excise that area. And CIN after any sort of treatment, even if you do hysterectomy, still needs follow-up. It is
Yeah,
not
then you have to do
for 20
the
years. So
smear from the vault or HPV testing for
yes,
the
so
vault,
follow-up,
because it has been seen that it can recur. Vaginal intraepithelial neoplasias can
exactly,
recur up to like
exactly.
25 years.
Exactly,
So
exactly. So
it
follow-up
has
is
to be
not,
done in those cases.
hysterectomy is not the answer because is not an alternative to follow-up. So
Yeah, yeah.
follow-up is necessary even if you do hysterectomy. So I think why it's subject to a patient to a hysterectomy for such a minor condition, when you can go do with if it's a TZ1
Leap
and
conization.
CIN1, you can even offer thermal ablation.
Yes, yes.
Yeah, means cryo-freezing, thermal ablation,
Cryo.
leap conization, all these things can be offered. But thing is, if the patient is not willing to follow up, then maybe she would be better off, then at least that portion is removed.
But that okay, so in that case,
Yeah, in remote.
Ma'am.
why hysterectomy, ma'am?
Yeah.
I think that is
Yes.
more.
I
I think
think,
hysterectomy
I
has
think, you know,
more problems with
No, that is not as a
premature.
routine procedure. If the patient is, I said, she's not willing to follow up, she stays at a remote place in that condition. And because she's completed her family, then one can opt for that. But mainly, we have to go for cryo-freezing, we have to go for leap.
Shazadin, ma'am, you wanted to add
yes.
something, yes, ma'am.
As I think what I can see, Dr. Alka Gujral's inputs and inputs of Dr. Sarita, things are very clear. In case if it is CIN1, or in that particular case, the treatment very simply for by and large people is that simply you can do a cryocautery or thermal ablation. Thermal ablation, if you have, is better than the cryocautery. They definitely require a follow-up 20 to 25 years. And hysterectomy is too big a procedure for things like CIN1 and LSA. One should really not do it. If you tell her that she requires a follow-up, she will definitely come for a follow-up.
Yes.
This is what I feel, that the hysterectomy is too. But if she is in a camp
That is
situation,
not
and
the
she's
first
not in the city
choice.
of Delhi, just 1 minute. She's not in a city of Delhi. She's in a camp situations in village area, and you see that you have done a VIA which is positively, which is positive, and in case if it's a 3/4 of a lesion, 3/4 of the lesion has been there, she's definitely sent for getting a colposcopy done. But in case she still refuses, then you have no other choice but to do a CIN and CIN2. Here, I just wish to comment on the LEAP. The study of 50 years has come out from UK, which shows that CIN1 people, when they followed up, they found in good 8 to 10% of cases the disease was as it is after 5 years. And in CIN2, the disease was as it is in 15%. And in CIN3, it was 50%. So what I feel about it, that it in a country like ours, for CIN1, CIN2, there is no controversy at all. Do simply cryocautery or thermal ablation if you have, is better. And leap therapy is not really required for CIN1 and CIN2. This is what my feeling is. And majority of the people are not even trained into it. We talk about theory, but how many of us are doing it left and right? I think, we are not doing. And hysterectomy, I think I beg to differ. It is too drastic a treatment for CIN1.
Thank you so much, ma'am. So just to summarize, if a patient has a report of LCIN and ASCUS, if HPV testing is positive, we call in for a colposcopy within 3 months. If negative, repeat cytology in 12 months. If it's a CIN1, we call in 12 months for an HPV test or cytology. We can do an ablation or a cryo, but observation is definitely preferred to treatment for CIN1. I'm unable to
Here I just wish to tell you that WHO had definitely brought out in 2014, in situations where you find that the follow-up can be questioned, even CIN1 can be treated. There is no advisory is there for developed countries. They can come for 1 year follow-up, because the follow-up is essential, is there. You can be sure that the follow-up will be there. But if you feel the follow-up is not there, it is worthwhile treating even CIN1 cases.
Yes, absolutely, ma'am. Thank you, ma'am. So if I ask all the panelists, how many of you do pap smear LBC co-testing? Any day co-testing is always better. So what all you do in your practice? Dr. Alka, ma'am?
LBC, we do LBC most of the time, but some people maybe more educated class and all, sometime they want to offer LBC and HPV together.
Dr. Sarita
Because,
Shan.
or people who are coming from countries like yesterday, I had a patient from Nepal. She said they don't have HPV testing. So she said, I've especially come here to do the HPV testing. So LBC
Yes.
plus HPV, both testing we did for her.
Sarita ma'am and Sunita
Otherwise,
ma'am.
normally LBC testing first. And if something comes out, then it is the HPV testing.
Absolutely. Sarita ma'am.
Yeah, we don't have HPV test yet right now in our hospital. So we do LBC or a conventional PAP. Now again, co-testing, as I said, the guidelines do not recommend co-testing. It is it's either primary HPV testing or it is cytology. So I think because what they have found is a lot of evidence saying that the advantage of co-testing is not there. I mean, there's no advantage of co-testing compared to primary HPV testing.
Dr. Sarita, recently a study in the Australian journal, they said they are advising co-testing every 5 years for all their patients. That's
Yeah,
what
ma'am, we have to go up with the guidelines, not just one.
they are not guidelines, but like people are coming more for HPV testing
We
nowadays.
have the WHO guidelines now, which recommend
I
primary
think,
HPV testing.
we are talking about 3% cases who are getting the screening done in our country. Talk about 97% where urine pap smear is also not available.
Exactly.
Here I must make it very clear, conventional pap smear and LBCR stand at the same rate. Definitely, the second one is 3 times costlier than the conventional pap smear, one thing. And secondly, I think it's a high time that 97% of the patients, the gynecologist must get friendly with VIA, which is ₹1 test, and Willy, which is a ₹5 test. So for us to have 100% testing, and I'll tend to agree with Dr. Sarita that though it has been said that after 30 years, it will be much preferable that you do a co-test. But now in case you have a pap smear, plus you have an HPV testing, I think HPV testing will be better than any.
Thank you, ma'am.
In our institute,
also
we
do
don't
VIA
have
for a lot of
HPV
times
testing.
and yeah, VIA also we do. It's a mix of PAP and
HPV testing, ma'am, in a private sector, it is available, though it is costlier. And I think the government of India is working on it. Their labs are working on it, and maybe in 6 months to 1 year time, you will have a test available.
Yeah, we in our institute, as of now, HPV testing is not being done, but our microbiology department, they have now about to start this PCR-based assays, and for all the genotype of HPV, and then we'll go further. And as of now, we are doing VIA in young women and cytology. Conventional cytology. We do not have LVC in our institute.
Ma'am,
In
VIA
ESI
and
hospital.
Willy is at par with pap smear. Either you do one thing or the other.
Same sensitive, almost sensitive. In fact, sensitivity specificity is better in young women as compared to postmenopausal women for VIA. Yeah, definitely.
Yes, premenopausal because the squamocolumnar junction is seen, so VIA is better.
Yeah.
Postmenopausal VIA is not the test of choice. PAP is better.
Exactly.
Dr. Neena,
Sarita,
ma'am.
Dr. Sarita, I have one question for you. Sorry, Dr. Neena, आप पहले बता दो. Then
I was
I'll
just
ask.
saying that since I'm working in Fortisla farm where the problem of money is not a problem, but in younger girls who are sexually exposed to multiple partners and they start sexual life early. So doing HPV repeatedly in younger girls makes no sense because the body is going to get rid of that naturally also with their own
HPV testing is recommended only after 30 years, not before that.
Yeah, that's what I'm saying. Younger girls, I mean, between 30, 35 as well. So, but the patients, once you explain it to them, that if you get the PAP duo test done, and then if it is all right, you don't need to repeat it for 3 to 5 years. So sometimes patients, after explaining, you have to talk to them. Although I understand in government hospitals, you don't have time to talk so much, but here we have an OPD of 10 to 20 patients. You can explain it to them and then give them a choice if they wish to get it done.
Dr. Poonam Sachdeva, ma'am, in your practice?
Yeah. Can you listen to me? Yeah.
Yeah, we can hear you.
We can hear you.
Yeah. Sorry. I didn't follow the question because there was some issue with my joining in. My video was not working initially. My mic was also not working.
Ma'am, what do you do in your routine practice? Pap
Yeah,
smear,
we are doing
LBC or
LBC
co-testing?
routinely. We are doing LBC routinely.
Oh,
Yeah. HPV is still not available again because of the constraints. It's a government sector. So any affording patient can go and get it done from outside, like private. And not routinely we are able to do because of the same constraint, financial constraint.
Raka ma'am, you were saying something on this?
Yeah, I just wanted to ask Dr. Sarita that, okay, fine, we've talked about pap smear and HPV DNA. Now, if you're sitting, like we are sitting in the OPD and we want to advise a patient, so what test do we tell her? कि नहीं आपको ये कराना है. I mean, not depending on government hospital or private hospital, but for the patient.
HPV, of course, if she's more than 30.
And if she's less than 30?
Here I just wish to tell you about thing, whether I'm sitting in 3-tier, 2-tier, or in a city of Delhi. Pap smear should be done routinely for all patients. Unless she says she cannot do it, then you have to do VIA and VLI. And if patient is more than 30 years, it is always good to combine it with HPV. This is our policy is. Just banking on HPV, we are not doing it. We're definitely combining it with VIA and invariably with the pap smear. This is what we are doing.
Yeah, so the HPV has to be a validated HPV test, like either Roche or a hybrid capture HPV test. It cannot be, any HPV test which is non-validated. So because that is the problem with, because a lot of labs are coming out with HPV tests which may not be validated. So if you have a validated HPV test, I would trust that more because LBC, the cytology has the sensitivity is very, very variable between 20 to.
No, Dr. Sarita, we are not just trying to say negate pap smear or VIA VLI. 30 years plus, we'll definitely get an HPV done, or less than 30 years, whenever you find CIN1 and other pathologies there, then we definitely get HPV done. The problem is majority of the patients, in spite of the best lab in the city, the validated or not validated, even if you find CIN2, CIN3, and you find HPV is negative. So I think no lab is validated, doctor, as for the city of Delhi is concerned. I'm not talking of America or any other country. I'm talking about this particular country.
Yeah,
So moving on to
is not positive.
There are, I suppose, thin prep, sure PET. These are private companies that are supplying to hospitals, and I think those are being used from last many years, and maybe they are reliable.
Thank you so much. Moving on to our next case, keeping this as basis, 46-year-old para 6 living 5. She came with complaints of vaginal discharge for 3 months. She was an obese female. Her cervix was unhealthy on first speculum examination, which bled on touch and was flushed with vagina, and there was ectropion. Her vaginal findings were normal, and the LBC report, it showed to be HSIL. So I would request Dr. Sarita Shamsundar ma'am, what will be your further plan of management in this case?
So any patient coming with HSIL, I would straight away go for colposcopy.
So we did a colposcopy in this patient, and these were the findings found.
Yeah, so this appears to be a very high grade lesion. The cervix there's a lot of bleeding. So I cannot say the colposcopy is adequate. I can see the squamocolumnar junction, so it looks like transformation zone type 1. And there's a very dense acetovite area at 9 o'clock position, and which is also ID negative. And this, in fact, looks like CIN3 to me, maybe microinvasive. And in fact, going on to the fornices also.
So we did a biopsy with endocervical curettage in this patient. It showed to be CIN2 with a normal ECC.
Why
So
was
with this
cervical curettage done, Pancham?
Ma'am, it looked very unhealthy, and we were thinking that maybe endocervix might have been involved on
No,
gross
it doesn't look
examination.
like it's going into the endocervix. The lesion is right out in the transformation zone, and it's looks like a transformation zone type 1. So endocervical curettage is only indicated when the lesion is going to the endocervix.
It was slightly suspicious, so we proceeded with that. But then the report came out to be normal, yes, of course, and with CIN2. So with this report, how, with your experience, ma'am, how will you proceed with this?
Well, it looks more than CIN2 to me. So I would go for a colonization. I would go for a bigger biopsy.
So with this patient, we did a cone biopsy depending because the findings were such. The cone biopsy report showed CIN2 with free margins. And further follow-up we did was co-testing for 1 year. After 1 year, NILM with HPV
Still, I
negative.
would get
So
the
any difference of
pathologist.
opinion?
Yeah, I would still get the senior pathologist, more experienced person to review this cone.
Okay.
Because there are areas which are really dense and which
Yes,
could
they
be
were there. Yes.
CIN3.
Yeah,
If it is
looks higher lesion.
Yes.
Yeah, but it came out to be CIN2. So yeah, that's what. So the next question was this: suppose this was a CIN3, then
Yeah, so if it's CIN3 and if the margins are negative, endocervical margins are negative and ectocervical, then I would just keep the patient on follow-up, call her after 6 months and then after 1 year.
okay. Thank you, ma'am. And this was just for the.
Can I make a comment, Dr. here?
Yes, ma'am, please.
We subject the tissue for histopathology examination because we feel that the opinion is final as far as the histopathologists are concerned. And just saying that I feel this and you feel this, that is not done. If it is they have reported CIN2 is there and the margins are free, then we should just take it.
No,
there are simpler options are available of treating these patients with thermal ablation. That's what my viewpoint is, and that's what viewpoint is. I think we have to think about this. They're tier 3 city or tier 2 city.
Maybe that's not the
thermal ablation.
I mean, that's not the point. I mean, there have been differences in reporting of by pathologists. So it's always we have a tumor board, and in the multidisciplinary meeting we discuss the findings, and then there have been differences in the reporting based on the experience, which happens even with colposcopy. Anything which is subjective, which has a visual interpretation, there could be differences in the interpretation, which is the same with histology also.
Sharda ma'am, your mic is muted, ma'am.
We are talking about a big country like India. Whatever we are talking about, we should generalize it. A person is sitting in a remote area, in a smaller area, and I think we would talk about the treatment of that kind of strategies there. Follow-up is must. Follow-up is every 6 months is must. But just because you think about it, the patient should have a code. That's not done.
No, madam, there's no harm in getting another pathologist opinion when the colposcopy is showing.
उसके बाद नहीं, उसके तो कोई बिल्कुल क्वेश्चन ही नहीं हो रहा है. अगर आपको डाउट लगता है कि इसकी इंटेग्रिटी नहीं, इसको नहीं आता, दूसरे अच्छे पैथोलॉजिस्ट के पास ले जाओ, वो मैं समझ सकती हूँ.
हाँ, बस इतना ही. हाँ, second pathologist opinion is needed when a colposcopy is showing higher grade lesion. So that's what it is.
Tumor board होगा सबका. Everybody is not sitting in Safdarjung hospital.
No, not tumor board, madam. Otherwise, also pathologists, we can have opinion of second pathologist when the colposcopy is showing high grade lesion. So that's what it is. There's no harm in getting it. Is not necessarily to go to the tumor board, just otherwise. So that we are sure that what type of treatment is to be given. That's the only thing.
I request Dr. Raka ma'am to take forward from this, ma'am, from case scenario 4.
Okay, thank you. So we have a 45-year-old woman, unmarried, sexually active, obese. She came for a routine checkup. So on examination, the cervix was normal, vagina healthy, uterus was anteverted, normal size, bilateral furnace is free. An LBC was done which showed AGUS and her HPV DNA test was negative. Dr. Poonam, how would we proceed with this patient?
Am I audible?
Yeah.
Yeah.
Pancham, can you move the slides?
For this patient, very good evening to all of you. The further tests that should be done should be endocervical sampling and endometrial sampling along with colposcopy. And if whatever is found to be abnormal in whichever aspiration of the endocervix or endometrium has to be dealt with. If all is negative, like nothing is positive, then she should be subjected to same test at 1 year and 2 years, and again negative, subject to routine screening. But if anything is positive, then that has to be dealt with accordingly. If it is endometrial pathology, manage as per the guidelines. If it is endocervical pathology, depending upon what we get, whether we get AIS or we get cancer or we get CIN, we manage accordingly. So the
So this
sampling,
patient
further
was,
sampling, next step is
yeah, so
sampling.
all right. So she was subjected to a colposcopy and endocervical curettage, and we got a report of adenocarcinoma in situ. So now where do we go?
So for this particular scenario, with the ECC report of adenocarcinoma in situ, we should do a diagnostic excision procedure. And I presume that the endometrium is evaluated and is negative, because we have to evaluate endometrium simultaneously. And in the diagnostic excisional cone, that's a cone biopsy, we have to check whether it is in situ or it is invasive or it is micro-invasive. Then accordingly, we stage the patient if it is cancer and manage accordingly.
So you would advise a conization?
Yes.
For her, I think situ means it is not invasive, it is micro-invasive. It is not invasive. It's not micro.
Yeah, it is in situ. Yeah.
It is in situ. It is endocervical curettage report. But by doing a diagnostic cone, we will get the details and the depth and everything, whether it is pre-invasive or invasive, and accordingly we'll manage.
Okay, fine. Yeah. So Dr. Poonam, we have one more question for you. Sometimes, we get patients in our OPD, they carry a pap smear report and it shows squamous metaplasia and they are like, scared, hame to cancer ho gaya. So now how will we counsel such a patient and how will we follow her up?
The very simple language that we use is that squamous metaplasia is not cancer, and it is just a cell which is immature squamous cell, and it will eventually mature into a stratified squamous, and it's on the surface of the cervix. Healing is taking place. That's how we explain that. Not to worry. Yes, we do get patients who come with a hysterectomy advice based on squamous metaplasia highlighted by the practitioner, which is not right. So we have to counsel them not to take it too seriously and just to keep themselves on a follow-up and just relax.
Okay, and how soon do we call them for a follow-up?
Maybe depending upon symptoms, persistent discharge and all, if there is any finding on the cervix, depending upon that, we can treat it and we can, if it is an erosion, so we have to follow and treat it accordingly. Maybe we can give cryo also.
Can I just ask, why do you need to follow up squamous metaplasia?
Exactly. No, according to the symptoms.
No.
On this
I'm just saying, okay, she's come with this report. Now, do you want to repeat a pap smear?
But why do we need to follow her up?
No, just repeat a pap smear.
If she is symptomatic.
That is a different story. We're talking about metaplasia. We don't need any follow-up. It's normal.
I think she should be put in the same category as any other patient and just let her be.
So basically, we
review all the things in the pap smear. If everything else is normal, then she can just go for routine screening.
All right. So now we come to our fifth case. This is for Dr. Nina. Dr. Nina, we have this lady, 30-year-old lady, 28 weeks amenorrhea. She came to us with complaints of pain abdomen. On examination, she was 28 weeks pregnant, single live cephalic presentation, uterus was relaxed. On per speculum, the cervix was looking very unhealthy. So a pap smear was taken and the cytology report showed us HSIL. We did a colposcope. Yeah.
The first and foremost, I'm very impressed that lady at 28 weeks with pain abdomen with uterus relaxed, the PS was done for her and also a pap smear was taken for her. Congratulations for that.
I think somebody was very, very free in the OPD and they really examined her well.
Good.
So then,
Next.
So then, since it was HSIL, a colposcopy was done. And we saw transformation zone type 1, green filter had a mosaic pattern, iodine no uptake, distinct yellow, the sweet score was 6. So a biopsy.
Definitely a colposcopy biopsy is required in such a patient, irrespective of the gestational age, because although the rate of growing into invasive cancer with HSIL is 0 to 0.4% till the patient delivers kind of a thing, but it needs to be sorted out what's happening in the body. So definitely colposcopy biopsy is required. And if the report again shows HSIL, then in each trimester, colposcopy should be done. If it goes back to LSIL, then we can wait 6 weeks postpartum. If it is again HSIL, then again 6 weeks postpartum. So because we have to rule out invasion irrespective of the gestational age.
All right. So what if, fine. So we took a biopsy and it showed CIN2. So then, as you told us, colposcopy was done in the next trimester. And again, it showed the same findings. And patient was counseled and she deferred treatment till 6 weeks postpartum.
So definitely,
Fine. So I think,
yeah, that's what I was exactly saying, that if it in the next report, if you feel it is low grade, then 6 weeks postpartum, you do colposcopy. If every trimester you have to do colposcopy with HSIL, and definitely since there is 0.4% risk of developing into invasive cancer, so we have to see and review with colposcopy 6 weeks postpartum. And if it turns out to be invasive cancer, then that is the major problem. What to be done? According to we have to then counsel the patient according to her gestation, according to her wishes, according to her attendant wishes. Then it becomes a big thing, and we have to include the oncologist. Then depending upon the gestation, whether she wishes to continue the pregnancy, whether she wishes to have a definitive treatment, then every case has to be individualized if it is invasive cancer. Although it is very rare to have invasive cancer in the younger age group, but still if it is there, it is there. And each case has to be individualized according to the patient's wishes. If she is closer to term, then ideally by giving her steroids and then delivering her with cesarean section is an option. If it is in first trimester, then depending upon the situation, we have to see how to terminate the pregnancy and then go in for definitive treatment. There have been cases where even in early stages of CS cervix, people have done with fetus in situ radical hysterectomies have been done in such. There have been case reports.
I would like to ask the other panelists their opinion on this case. Dr. Sarita? Dr. Sunita Malik, ma'am, would you like to give your opinion on this case?
Kindly unmute, Dr. Sunita, ma'am.
I'm muted now.
Sorry. Yeah. So if it is CIN1 on biopsy, which I've already taken, and in low-grade lesion, we just need to do a colposcopy at 6 weeks postpartum. That's what it is. And it may not be there afterwards also, you know. CIN1 is known to have...
He was CIN2, Dr. Sunita Malik, CIN2.
ma'am.
Higher grade. So we have to repeat in every trimester. And then 6 weeks postpartum. We don't have to rush for treatment straight away. That is the main point. Unless it is invasive, then only we can go for it. Otherwise, with CIN, we wait till delivery and then later on we follow them up. So that's what it is.
And Sarita is also here.
Hello? Yes,
Yeah,
ma'am.
Dr. Sarita.
Yeah, so yes, as Dr. Malik said, I agree. So it's basically you just need to follow every trimester and see whether it is becoming more aggressive or it is remaining the same. So if it is remaining the same, you just need to follow up after delivery. And so rather than 6 weeks, 12 weeks is said to be better, 12 weeks after delivery. And actually the lesion on colposcopy, to me, it didn't appear to be, really high grade. The indication for biopsy would be something with a sweet score of 8 and more, which is more likely to be suggestive of cancer, because a biopsy in pregnancy is not easy because the cervix can bleed horribly in pregnant cervix. So controlling the bleeding after biopsy can be really difficult.
Okay, thank you very much.
Only when it's really
necessary. Yeah.
Really necessary, yeah.
Okay, thank you. So Pancham, would you give take home messages from our panel. CIN persisting for 2 years, we offer ablation or excision. CIN 2/3, we do a diagnostic excision. CIN in pregnancy, if it's a high-grade lesion, we do a colposcopy in every trimester. CIN in the age of 25 to 29, we follow with cytology or co-testing at 1 year. Screening to be done from 25 to 65 years or till 25 years post-treatment, whichever is later. Even if one is...
Raka, can you go back to the screening?
Yeah, one sec. Pancham, yeah.
So this screening is primary screening.
Primary screening, yeah.
So the guidelines for primary screening are 25 to 65, not 21 years.
Okay. Do I read up to date? Okay, fine. Agree.
24 to 65 to be more
24 to
precise.
65. Okay, yeah. Up to date says 21.
No, the
your
guidelines
guidelines say 24, 25. Okay. So we'll stick to 24 to 65.
And HPV after 30 years.
Yeah, HPV is after 30. Yeah. So that's what we're saying. Even if one is sexually active before 21 years, PAP test not required, less than 30 years, no need for HPV testing. Low-grade lesions, you triage with HPV, /repeat cytology. High-grade lesions, you need colposcopy. VIA, Willi positive, screen and treat, or colposcopy. All right. HPV 16 or 18 infections have the highest risk for CIN3 and occult cancer. So additional evaluation is necessary even when cytology results are negative. If HPV 16 or 18 testing is positive, additional laboratory testing of the same sample is not feasible. Patients should proceed directly to colposcopy. I would like your opinion on that, Sarita. And HPV testing or co-testing at 3-year intervals for at least 25 years is recommended after treatment of histological HSIL, CIN2, 3, or AIS.
Yeah, so so this sentence, HPV 16 or 18 is positive. Additional laboratory testing of the same sample is not feasible. Yes. So
then you proceed directly for colposcopy, right?
Yes. HPV 16 or 18 positive is definite indication for colposcopy. There's no need of even doing cytology. I mean, straight away you should go for colposcopy. Cytology is indicated if it's a non-HPV 16-18. So if HPV positive, but it's not 16-18, then cytology can be done for triage. You're not able to go for colposcopy. But I see, if you see the guidelines, the WHO guidelines have come out very clearly, and all the algorithms are very clear. HPV 16, any HPV test, if you're able to do a triage, you're able to find the genotype. If it's 16-18, then it's a straight away indication for colposcopy, because they are high risk, very high risk of having CI. And the other HPV types should be triaged with cytology.
Okay. Right. So,
and regarding the pap smear also, anything more than ascus is an indication for colposcopy.
Anything more than ascus is an indication?
Yes, yes. Not even, no, LSIL is an indication for colposcopy. So these are...
If it's HPV negative, then it can be.
Yeah, if HPV negative.
HPV negative, then you can follow up.
You can follow. But anything more than ascus, if you're only going for cytology, then that is an indication.
Ma'am, can I ask one question, please?
Yes.
Suppose somebody is fully immunized and received all 3 doses of HPV vaccination. Even then, HPV can come positive later in life.
Yes.
So you are, because it is recommended to do that even the patient is immunized.
Yes, screening is recommended even
You're
after
only
vaccine.
immunizing for 9 strains. There are so many.
But those are the most virulent ones. So sometimes patient says कि हमने तो पूरा vaccination कराया, हम क्यों कराए? अभी भी हो सकता है क्या? So these questions are there sometimes.
No, that was the other thing is we don't have long-term results as of now, which have been there. So still, even if we are doing vaccination, so we need those long-term results which have not been published as yet. They are just publishing the immunity part, but the screening and then further then we are getting other types of cancers also. So we need to screen them even if they are immunized.
Screen with HPV as well.
Yes.
Okay.
There is a question in the chat box. 34-year-old on routine screening, LBC negative and HPV 16 positive. Do I offer colposcopy or repeat?
Yes, colposcopy.
Colposcopy.
Okay. And
See, we have seen cases where there is cervical cancer also and PAP is negative. So if I would always trust the HPV or trust my eyes.
Depends on the person taking pap smear. Also, so many pitfalls in taking pap smears.
So if
That's
you're taking from the dead cells,
yeah.
I know.
the periphery, it will come negative.
Yeah, exactly.
So we thank all the panelists. Thank you so much, ma'am, for your pearls of wisdom. Thank you, Shardajan, ma'am. I actually came across a study while reading through this. There was a trial of management of borderline and other low-grade abnormal smears, Tombola. It was a trial done in Scotland. So moving ahead, it was just a screening method. They compared the LBC with the pap smear thing, and they came out that cytology, yes, should be done. So we are going to have a Tombola game. Everyone who is here, anyone interested, I can share the tickets in WhatsApp group.
You haven't sent the tickets.
I have sent the tickets, ma'am.
Okay.
To almost Sarita ma'am, आपके पास भी आगे होंगी. Dr. Alka ma'am, I am sharing yours.
I
Yes,
don't
if you like.
Where did you send?
Yeah.
Ma'am, group, the office bearers group.
Office bearer पे है रेनू मैम.
Okay.
आपके नाम की टिकट है.
ठीक है. Found it.
Yeah. So before we go on to the online Tombola, I sincerely thank all the esteemed panelists, the moderators, and Sharda Jain ma'am for giving their valuable inputs. I think they have covered right from A to Z of the abnormal pap smear, and we have become much, much more wiser. And apart from that, my sincere thanks to all the faculty members for their talks, Renu ma'am, Rama Joshi ma'am, and the chairpersons, Dr. Pooja, Dr. Jaya, Dr. Nimi, and Dr. Minakshi Ahuja for making this webinar good by giving their good contribution and giving their value comments. And sincere thanks to the backend team of the Shield. Sahiti is there and Chitra is there for managing it so well. And thank you so much. And now please stay back for the Tombola. We have good, exciting prizes. It won't take long. We'll just finish it in 15-20 minutes.
So
Over to
anyone who is
Pancham
not
and Sujata.
can
Yeah.
ping me. I can give you. I can send the tickets. Everyone. Anyone else who doesn't have?
Dr. Vandana Narula का message आ रहा है, not received the ticket. मुझे भेज दो. I have her number. I will share the ticket with her. You send it to me.
मैम सुनीता मलिक मैम आपको मैंने पर्सनल में भेजी है मैम.
अच्छा पर्सनल पे. अच्छा ओके.
मैंने
I just see. Okay.
Yes, ma'am.
Thank you. Yeah.
So the prizes will be given in the not the obviously you can't get a prize online. So when we meet in for our January meeting, the physical meeting in January end, we will be giving the prizes for Tombola.
Pancham, is there a way where we can share the tickets in the chat box? कुछ ऐसा है क्या?
मैम मैं फोटो भेज रही हूँ सबको.
I mean, my ticket left part is not the one with below, you know.
नहीं मैम आप उसको क्लिक करोगे तो आ जाएगा.
क्लिक करो तो पूरी आ जाएगी.
पूरी आ जाएगी.
पंचम चैट बॉक्स में नाम लिखो और टिकट छाप दो एक ही जगह फटाफट.
हाँ 3-4 ना इकट्ठे.
नाम लिखो और टिकट डालो so that we don't waste time in this. And then let's start in a few minutes time. It's already past 5 o'clock.
1 second.
Dr. Sharda.
चैट बॉक्स में नहीं आएगा. आई थिंक पंचम यू शेयर योर स्क्रीन, शायद उसके नीचे फिर हम नाम बोलते जाएंगे. चैट बॉक्स में टिकट जाएगी. साहिती, चित्रा, व्हाट्स द वे आउट?
नहीं फिर स्क्रीन शेयर करो. Listen, let people click a picture from their phone.
हाँ स्क्रीन शेयर पे.
देर मत करो.
हाँ you share your screen.